Sharina, please.
So, hi, good afternoon, ladies and gentlemen, and thank you, Prof. Hajjaj, for the introduction. So today I'm going to talk about early diagnosis of IPF challenges and opportunity. I don't have any conflict of interest related to this presentation. So these are my learning objectives. We'll discuss about IPF diagnosis criteria, discuss the challenges in making early IPF diagnosis, and explore the strategies to facilitate early identification of IPF individual. So as we know, we have more than 200 types of ILD. It can be grouped as an interstitial, idiopathic interstitial pneumonia, autoimmune ILD, hypersensitivity pneumonitis, sarcoidosis, and other types of ILD. In idiopathic interstitial pneumonia, one of the main causes and important causes of idiopathic interstitial pneumonia is IPF. In fact, this is one of the type of ILD that has a worse prognosis. It has 5 years above of 2 to 3 years. IPF account for 20% of all ILD. So not all pulmonary fibrosis is IPF. So 20% is IPF, and the remaining could be due to other type of interstitial lung disease. IPF considered as the main cause of a progressive fibrosing ILD. And we know that patients with progressive fibrosing ILD, they tend to behave differently than other type of ILD. They tend to progress fast, and then patients with a progressive ILD, including IPF,
Sharina, can you, Dr. Sharina, can you the slides and move them because they are not expanded?
Oh, really? Sorry about that. Shall I click? Is that okay? Prof. Hajjaj?
Not yet. Not yet.
Okay, how can I do that? Let me see. So shall I click in? Is that here? Slideshow? Oh, what now? Is that okay?
It's okay. Cannot then just go slides one by one. That will be fine because the slides are clear now.
Okay.
Can proceed.
Slides two. Okay. I don't know. Let me know what do you want me to do. Shall I go over each slide, or do you want me to keep it the same? Okay. So yes.
Yeah, we just want to that your matches this. So you have the pie chart now, which we can see the disease progression. This is that we see now.
Yes.
So this is what says the disease progression, the different HRCT. So we just want to correlate the slides with your talk.
How about now?
Maybe the organizer just try to help Dr. Gentile. Yeah.
Oh, do you want me to? So, okay. Zoom, no. Okay. So I don't know, Micheline or any of the support can help me, please.
Dr. Sharina, are you speaking?
Yes. Can you hear me, Prof. Hajjaj?
Yeah, we can hear you now, but to expand it, it's okay. You just go by one with the slides on the side.
Okay. Let me see again. Sorry.
Can you check the sound?
Okay, I'll just click share again. Okay, I'll go to the PowerPoint. You want me to go slide by slide or zoom?
Yes. It's okay.
Okay. So I'll go slide by slide, Prof. Hajjaj.
Yes. Go ahead.
No need to press the show slide. I press, okay. Okay. Oh, okay. Can you see my slide?
Yes, that's fine.
Okay, let me take this, get rid of this.
Just go ahead, proceed. That's all right.
Okay. So, so the disease progression is that once patient have a progressive fibrotic interstitial lung disease, patient will have decrease in exercise capacity, change in the quality of life, worsening cough and dyspnea, and recurrent hospitalization, plus, okay. So we know that in a healthy subject, lung, we lose about 50 ml per year, lung volume. In IPF patients, it's about 150 to 200 ml per year. So patients with IPF lose about 150 to 200 ml per year. So therefore, early identification of IPF and starting antifibrotic is essential and needed to flatten the curve and reduce the reduction in the volume and prevent any loss of lung function. We know that we have idiopathic pulmonary fibrosis, which is antifibrotic, and there are two antifibrotic approved. We have pirfenidone and nintedanib, and both of them reduce the functional decline in FVC and the progression of the disease. Okay. So let's start with the case. We have Mr. K is a 68 years old, 68 years old gentleman, ex-smoker of 30-pack year, retired, used to work in the military, was seen in a GP on August 2014 with a chronic cough. The GP ordered a chest X-ray, and this is the chest X-ray. And you can see, basically, this is the chest X-ray in 2014. There is some interstitial changes and abnormality in the lower lung zone. So his GP referred him to pulmonologist. He was seen for abdominal chest X-ray, and he was seen 2 months later. Based on the pulmonology assessment, initial pulmonary assessment, patient had mild exertional dyspnea when carrying heavy object, MRC dyspnea scale 1/5 with intermittent cough. He also had no exposure to hypersensitive pneumonitis or environmental exposure, no connective tissue disease symptoms, and no exposure to drugs. He had finger and crackers in physical examination, and his pulmonary function test showed FVC of 62. So chest CT scan was ordered, and you can see that this is a CT scan. And the CT scan, as you can see, this is like basically involving the changes mainly involving the lower lobes. You can see there is a periarticulation, there is traction bronchiectasis, and there is a honeycomb. And this is what we call a UIP pattern. So based on that, he was diagnosed to have idiopathic pulmonary fibrosis. So he was started in nintedanib 150 milligram twice daily in August 2015. and was seen in a regular visit in pulmonary clinic. I've seen him this month. He's doing well, has the same exertion dyspnea, muscle dyspnea scale of 1/5. He has stable, which has been stable, and his 5%, which has been stable as well over the last 18 months. This is his chest CT 2014 and 2021. You can see that there is some changes. To me, there's some slight increased changes, but it has been compared to previous CT, more or less the same. In 2018, the IPF diagnosis guideline was released, which was an update for previous 2011 guideline. And based on the guideline, you need to have a clinical context, which is basically no HP, hypersensitive pneumonitis or occupation exposure, no CTD symptom, and no drugs, and as well as the age is more than 60, where the former smoker, and typical insidious progression of dyspnea plus crackles. We need as well a CT scan. So beside the clinical context, we need the CT scan HRCT appearance of classical UIP, which is a peripheral reticulation, honeycombing, and traction bronchiectasis. This is basically the radiological pattern of ILD, and for idiopathic pulmonary fibrosis is mainly they have a UIP, classical they have a UIP pattern, and the UIP pattern in CT is corresponding to the histopathological pattern as well. It's 90 to 100% probability of having the same histopathological UIP pattern in lung biopsy. So if you have the UIP pattern in CT, most likely the histopathology in lung biopsy will be the same. This is basically the same, honeycombing, traction bronchiectasis, and peripheral reticulation. So this is the IPF diagnostic approach. You need to have, if you're suspecting IPF, you need to know if there is any cause, associated condition, do a HRCT. If you have a UIP pattern, then it's an IPF. If you don't have a UIP pattern, you have to discuss in the MDT and see if we need a bronchial lavage or lung biopsy to reach the diagnosis. So what's unique about our case is basically the patient seek the medical care earlier for persistent symptoms, which I think being as a military and regular exercise, he detected shortness of breath and symptom earlier. And the GP as well did the chest X-ray from the initial visit and identified the abnormality and referred the patient directly to pulmonologist, whom and the referral was within. Pulmonologist order HRCT and PFT. There was available resource for a pulmonologist to do further investigation of the CT of the chest X-ray abnormality and ILD. And the pulmonologist identified UIP pattern earlier and established a diagnosis of IPF without the need for invasive intervention like bronchoscopy or a biopsy. And even the starting antifibrotic was earlier. So overall, this patient, from the time he presents to the GP with a persistent symptom, to the GP, to the time the GP was assessed, to the time seen by the GP, had a chest X-ray and referred to pulmonology, and reached the diagnosis was about 3 to 4 months. And started the treatment on August 2015, once the antifibrotic was approved and available in the market. So one of the main challenge for early IPF diagnosis is basically the diagnostic delay. We know that if we have timely diagnosis of IPF, it will reduce unnecessary investigation and could improve the outcome in terms of starting medication and earlier referral to the lung transplant. We know as well from this study, which was published in 2011, which include 129 patients with IPF, that those who was diagnosed more than 4 years have a lower survival compared to those with a diagnosed less than 1 year. So this basically irrespective and independent of the disease severity. So the conclusion of this study is that delaying accessing to a tertiary care center was associated with a higher mortality rate in patients with the IPF, and regardless of this disease severity. So why do we have a delay in the diagnosis? What are the factors that contribute to the diagnostic delay? One of the things is IPF, the symptoms. IPF symptoms are non-specific. It's shortness of breath, cough, fatigue. It can overlap other causes of respiratory condition. And in fact, like cough and dyspnea are considered as a non-specific symptoms. Velcro crackles in the auscultation are specific, but they're not sensitive enough. And the finger clapping might be a sign of advanced IPF. So don't wait for the finger to clap to diagnose IPF. Another factor contributing to diagnostic delay is the path of diagnosis is often longer. It's assessing the patient, doing a chest X-ray, getting approval for a CT and a pulmonary function test. So the diagnostic path is sometimes longer, is often longer, and which contribute to delay in the diagnosis of IPF. Many patients have misdiagnosis and given ineffective treatment. These studies assessing the barrier to a timely diagnosis of interstitial lung disease. They surveyed a couple of patients with interstitial lung disease, and they found that more than 55% reported more than or equal one misdiagnosis. And for patients, mainly the misdiagnosis were asthma, mainly were asthma, pneumonia, and bronchitis. For risk factor, there are also risk factor for diagnostic delay. These studies basically assessing the risk factor for diagnostic delay in an IPF patient. And they group the risk factor into a patient delay, patient factor, GB delay, or patient GB factor, hospital factor, and special center factor. And what is found in this study is that the median diagnostic delay from the time the patient presents to the GB with a symptom until diagnosis was 2.1 year. And the main contributing factor for the diagnostic delay in this study was the patient factor. Patient is trying to ignore the symptoms or minimizing or relating the symptom to the age. GP factors, sometimes diagnosis late, and you diagnose the patient as asthma, giving the patient inhaler, and which delay the diagnosis. And community hospital factor is basically availability of a resource to do a CT scan and pulmonary function test and reach a diagnosis. So this is basically 3 factor: patient factor, the GP factor, and community hospital. So what are the strategies to facilitate early diagnosis of IPF? Well, if we group them into a patient factor, GP and pulmonology, or community hospital factor, we can group the patient factor first as that if the patient had dyspnea or persistent cough, then they should not ignore the patient. They should not ignore the symptom, and they should seek a medical advice. So we need to educate the patient. We need to have an awareness and educational through all way of like social media or even in the GP and the clinic and the hospital, is that we need to educate the patient not to ignore the symptom and seek medical advice. How about in the GB level? In the GB level, if you have crackles, if you listen to crackles in the physical examination and you have seen that the patient has persistent unexplained symptoms, then you have to consider pulmonary fibrosis and refer the patient to pulmonology earlier. For a pulmonologist and radiologist, we need to know, we need to assess the HRCT, see the ILD pattern and the risk factor for ILD, do a comprehensive assessment and refer to ILD center. In the ILD center, we have also, we need to facilitate, we need to have educated about the risk factor of ILD, perform multidisciplinary discussion, multidisciplinary approach to reach a diagnosis timely, and start antifibrotic medication. So this is basically the challenges and opportunities. You can group them into patient factor, GP factor, pulmonologist or local community hospital factor, and tertiary care factor. For the patient factor, we need the main challenge is that non-specific symptoms and lack awareness of IPF and misdiagnosis. So we need to the solution is to need to educate the patient of symptom and seek medical advice for persistent symptom. For the GP, we need to know, we need to advise them, recommend or advise and educate the GP to have a low threshold for patient with pulmonary fibrosis and timely referral as soon as possible. For pulmonologists in a local hospital, one of the big challenges is the volume, the low volume of IPF and unfamiliarity of IPF. As you know, community pulmonologists might not have the experience on diagnosis of IPF. So knowing the basic criteria for diagnosis of IPF and as well as having the availability and accessibility to refer the patient to tertiary center will help addressing this challenge. For the specialized ID center, we have the big challenge is a delay accessing the patient, delay in access and seeing the patient, and plus the limitation of the treatment option, trying to start the treatment earlier. I think this is basically what I have for the challenges and opportunities for an early diagnosis of IPF. Thank you.